I use the word baselines a lot, and I want to clarify what I mean when I use that term. Baselines are how your body is when we start care. So it's predominantly symptoms and signs. And symptoms are usually what people feel, and signs can be something that patients perceive, but it's more on my end to find the signs of the disorder. And here are the main ones that come to mind when we talk about symptoms and signs. Symptoms, of course, predominantly pain, but also numbness, tingling, discomfort, achiness, tightness. There can be any number of symptoms. It's what the patient feels. I can't feel it. When it comes to baselines, the most germane in orthopedics is range of motion. So what's important for me is that I know which ranges of motion to take for the extremity joint. If you have an extremity problem, for example, how much range of motion is normal, how to adjust that maybe for comorbidities or age or gender. And then I also make sure to take the range of motion baselines in almost all cases of the relevant spinal segments, because the spine is the fuse box and it's in control of your extremities. So for the knee, I will look at the low back range of motion. For the shoulder, wrist, or hand, I'll look at the ranges of motion in the extremity and also in the neck and or mid back. And I think that's a really key distinguishing factor between how I approach orthopedics and how most clinicians approach orthopedics, who are more laser focused just on the area where the person is complaining of symptoms. So range of motion, most important. Strength, probably number 2. We can use manual muscle tests in the clinic. I've mentioned before how those are fraught with problems because they test more the muscles, but nonetheless, they can be a baseline. Whether or not I think the muscle is the problem and contributing to why you can't hold against that force or not, something is preventing you from holding against that pressure. It could be something that the patient notices in the gym or in a different scenario, but in the clinic, I'm doing manual muscle testing of the relevant muscles or relevant motions to gauge if they're 5 out of 5, which is normal, if they're painful, or if they're just normal. Nerve tension is probably another big one that most clinicians are taking, especially in the presence of spinal symptoms that seem to be radiating into the extremity. We don't use nerve tension very often when it's an extremity disorder that has no spinal involvement. Functional baselines are often ascertained by taking functional questionnaires, which people circle: can you run, can you hop, etc. But for me, it's important to try to get a functional baseline in the clinic. So I'll take range of motion, strength, possible nerve tension, and then ask the patient, what can I have you do right now that would create your symptom if it's tolerable? It could be lying on your left shoulder. It could be getting up from the chair. It could be reaching behind you to tuck in your shirt. So a functional baseline can be kind of gleaned in the office, and if not, then it could be something out of the office. Every time I walk a mile uphill, my hip hurts. Every time I'm asleep, the pain wakes me up at 3 a.m. So something that you can't do in your normal function is a functional baseline. There's also other baselines that are not something I deal with very often, but taking a bone scan, for example, or taking an x-ray of a joint and looking at the integrity of the bone. You take that and you can do the intervention and retest that. Or if there's a fracture, you take the x-ray of the fracture, do the intervention, which is surgical or immobilization, and then retake the x-ray to see if that bone callus has formed around the fracture so that it's healing appropriately. You can also look at the cartilage with images, bone scans for bone density. Sometimes those are really relevant baselines for patients' complaints. Balance is another example of a baseline, not as common, but there can be things outside of just range of motion and strength. Maybe you have full range of motion and strength, but you can't balance, and we got to work on that. So when I'm taking my orthopedic evaluation, what's important is I know which ranges of motion to take, what they should be, how they should be adjusted for anything like gender or age or comorbidities. I know which manual muscle tests to do, how to interpret them, etc. But the gist of the exam for me is take the baselines, know which ones are relevant and really important to measure, and then for me, repeated movement testing is how I do the testing. Now, sometimes I use quick orthopedic special tests. Sometimes I ask patients to get images, and those are interventions or tests as well. But for me, the main test is repeated movement testing. So take the baselines and I'll move the knee into flexion 10 times and then retest the baselines. Or I'll take the baselines, move the neck into repeated retraction 10 times, 20 times, 30 times, recheck the baselines. For a diagnosis of joint derangement, which is what I find in 70 to 80% of patients, I will see quick changes in the baselines. But of course, baselines won't change quickly due to repeated movement in a particular direction if it's a ligament sprain or if it's a fracture. But in my mind, we're jumping to these problems too quickly without making sure that, in fact, the problem isn't just a joint being tweaked, that we need to get back on track. So if I arrive at a structural diagnosis or a diagnosis that is not a joint derangement, it's because I don't see the baselines change quickly with repeated movement testing, which clinicians have to learn. There's an algorithm about which repeated movement to use, how much force, how often, how many times in the set, etc. But getting good baselines is really important so that you can see if the intervention is helpful. You can also see if the testing is helpful. And patients at home are probably going just by symptoms, which is the best they can do. But if you can, you want to not only go by, does this change my pain or does this change my discomfort? You want to go by, does this change my pain and discomfort and also change my signs? Because at the heart of reversing a disorder is reversing both the symptoms and the signs. And I would say that by reversing the signs to an extent, you're getting rid of some of the pain as a byproduct, but you want to resolve the signs completely and get the musculoskeletal system back to 100% normal as best you can, so that the likelihood of a problem recurring is smaller and the likelihood that the pain stays away is greater.